Rehani, she'll send it. Shall I start? The PDF is mainly I used Hiran's note, and if you already have it, that's the note I used mainly. I just added some stuff to it, but I've anyway shared it. And there is something in nephrotic syndrome. This book concise has some really good boxes. Those boxes are very good. Just study those boxes also. I have put some of those boxes in that note, but some boxes are not. I didn't put it back into the note. So good if you can go through those just in the nephrotic syndrome chapter. Just look at those boxes. Okay, in the concise book. I'll try to finish this. It's a lot to do in 1 hour. But I'll try to go. If I'm going too fast, just let me know. So I'll start. Can you see the screen?
Yeah, we can see.
Okay. So I'll do it with first. Go with the history because it's a long case topic. I'll go with the history and then examination, the usual long case pattern. If I'm fast, just let me know. Because I'm trying to finish a lot in this. So just to give you an overview of just the history examination management, and then I'll just tell some of the questions that they can ask. Nephrotic syndrome is the case that I got. If you want to ask at the end also as to what questions I was asked exactly, just let me know. So initially in the history, in comes to the history, so there are two types of cases that you can get when it comes to nephrotic syndrome. One is that it can be a patient presenting for the first time with nephrotic syndrome, or the patient presenting who is already diagnosed with nephrotic syndrome coming with a relapse. That is the most likely scenario you're going to get. Okay, it's mostly relapse, but sometimes it can be a first time symptom as well, first time presentation. So in these patients, they usually come with edema, no, so it's generalized edema. So you're going to start your history with the main usual normal things that you're going to ask, introduction and all of that. I'm not going to go through that. Just at the description of the edema. So this is a good pattern to follow, which is you have initially the onset of symptoms, and then you ask about when did the mother notice. Then you talk about the progression. When you're talking about the progression, it's good to say as to where how the edema has spread. So initially, if the mother noticed a periorbital facial edema, and then where did it spread? It spread up to the ankles, or it spread to the scrotum or vulva. Did the mother notice swelling there? Abdomen, pleural effusion, pulmonary edema. You can't ask directly, and maybe not to better not mention it here. You can mention those two in complications. Then when it comes to the duration, obviously we ask how long it has been there, and then you can ask about any aggravating and relieving factors that the mother has noticed with the edema. If the mother says that it does not increase with anything and does not reduce with anything, you can leave it. You can just say there were no aggravating or relieving factors according to the mother. Then another thing is timing of the edema. That is, we ask whether it is more prominent in the morning or evening. That is because we know that usually in renal related diseases or nephrotic syndrome, the edema is worse in the mornings, whilst in heart failure it is worse in the evenings. That comes with prolonged standing. Okay. Then the other thing is what are the associated symptoms? Does the patient have the urine? Did the patient have any fever? Those are things you can ask. And any abdominal pain. Did the was the child dehydrated, and was the child having any exercise before the frothy urine? These are things you can ask because those are certain things that the patient will complain of if the patient has transient proteinuria. Then at the end of this description of edema, you can ask what the mother did. Okay, so this is first presentation. Okay, but it's very similar to this presentation also, but I'm just saying that this is the order. Then when it comes to the causes, now you want to rule out what are the causes for this edema. So here you will get an idea when you present this whether this is a renal system involving edema or a CVS system or whatever other system. But mainly you know that it's difficult to take it just from that part, but you will have an idea now. Then when it comes to the etiology, we know mainly going to talk about the other causes of edema, nephritic is not very prominent, but it can be. So for that, you can ask certain symptoms related to nephritic syndrome, whether there was a preceding throat infection, skin infection, and whether there was any hematuria. Then those things also you can ask in this other symptoms. Then for CKD, usually you can ask symptoms of CKD in the sense of when it comes to CKD, obviously we can't ask anything unless the patient has gone into end-stage renal disease, or the patient is with what symptoms of uremia. So those are the symptoms you can ask. If the patient has nausea, vomiting, if she has loose stools, those are the things you can ask, and itching and hiccups and all of that. Only if the patient has gone into what during the last stages, because if not, then the CKD is an asymptomatic disease otherwise. Then you ask some questions about heart failure, about orthopnea, paroxysmal nocturnal dyspnea, obviously depending on the age of the child. Okay, keep that in mind when you're working with ped, that some symptoms the child can't tell, so ask accordingly. Then symptoms for liver failure. This might be a little bit difficult to ask with protein losing enteropathy. Only thing you can ask is if the patient has a chronic diarrhea, that is for more than 14 days. If the patient has been having loose stools, then maybe there is some nutritional component to it, and the patient is losing some protein there as well. But remember that if the gut is also edematous, then also there will be reduction in absorption of protein and other nutrients. So that can also be a cause that comes afterwards. Okay. Then this is, you don't need to ask this. Then other causes of nephrotic syndrome. So now you have ruled out, you have asked for the edema, how the edema progress. You have come up with whether this is mostly renal or CVS. You have asked other causes of edema. You've brought down your differential diagnosis. And now, since you're most likely sure that this is nephrotic syndrome, within nephrotic syndrome, you're asking for these things depending on the whether what the cause it could be. Now again, don't ask these things if the patient is very clearly a young child coming with only proteinuria edema, and you are sure this is going to be minimal change disease, then you don't need to ask about all of this. But if you're not sure and there are some atypical symptoms that the patient is presenting with, the age is not within that recommended age, then you can ask about these things and you can highlight this. You can anyway ask it, but when you're presenting it, make sure how much prominence you're giving to these things when presenting it, depending on your rest of the history. Okay. Then for causes, we are going to rule out any hepatitis B or HIV. That's also about previous blood transfusions. If the patient has ever been jaundiced with Hep B, those are some things you can ask. You can ask about the parents' history, if they have a history of HIV. Then SLE, you can ask about the rash, photosensitivity, all that we know, joint pain, stiffness, those things you can ask. Then moving on, after the etiology, we go to the complications, right? So always remember history of presenting complaint, symptom analysis, etiology or differential diagnosis, then complications, and then finally what has been done. Okay, so when it comes to the complications of nephrotic syndrome, this is a good mnemonic to remember: infections, hypovolemia, and thrombosis. That is IHT. So in that, when it comes to infections, they are more likely to get infections. Now in nephrotic syndrome, the most likely infections that they get is when they are losing protein. Okay, that is when they are most likely to get infections, and that is why we usually cover for any. We give antibiotics in the management also, antibiotics during that period of when they are losing protein, and that is when they are more likely to get infections. So the most likely infections that they will get are spontaneous bacterial peritonitis, cellulitis, then other respiratory tract infections and urinary tract infections. So how are you going to ask for each of these? Spontaneous bacterial peritonitis, we know you can ask with fever with abdominal pain. In lower respiratory tract, you know how to ask. Cellulitis, UTI, so you will know how to ask. Okay, I'm going a little fast. If I'm going too fast, just let me know, because I'm trying to finish this within 1 hour. Then other one is hypovolemia. Now I'll tell again hypovolemia in the sense that you should remember in terms of nephrotic syndrome, the pathophysiology. Okay, that is also something. It's good if you can revise the pathophysiology between nephritic and nephrotic. And we know that nephrotic is a it's a hypovolemic state, while a nephritic is more of a hypervolemic state. That's why nephritic, they get hypertension, but in nephrotic, it's not, there is no hypertension, it's more hypovolemic state. Okay, so if you go and read about the how in which disease renin-angiotensin aldosterone system is activated, that might be a little bit helpful for you if they ask in your SEQs or even in the discussion about the pathophysiology of what gets activated. Okay, usually it is a nephrotic nephrotic syndrome that there is some this thing that gets the RAS system gets activated, while in nephritic it doesn't. But you don't need to know that in detail. But if you can, it will be a good addition for you to increase your knowledge about the pathophysiology part. So hypovolemia, you can ask about the dizziness, cold and sweaty extremities, and the reduction in the urine output. I'll tell about other symptoms also. They will also come with abdominal pain because of reduced perfusion to the abdomen. So that is with hypovolemia. Then thrombosis is T. So we know that they can develop thrombosis. So that is also because there is a disruption in the clotting system. Because the reason they develop thrombosis is another thing is they lose a lot of what these anti-clotting factors and all are lost during the with with the other proteins, right? So your antithrombin 3 and all of them are lost with the with the protein. Because of that, in addition to that, the liver gets more functional because liver starts producing, because liver there is less albumin, the liver will try to produce more proteins. So when the liver tries to produce more proteins, they produce more clotting factors. And another thing is because they are hypovolemic, these clotting factors will start getting more concentrated, right? So when the clotting factors are more concentrated, liver is producing more clotting factors, and you're losing anti-clotting factors in your protein in the urine. You have a state of hypercoagulability. So because of this, these patients get more likely to get thrombosis. In addition to that, they're usually, they are lying in the bed. They're not sent out to run and walk and all of that. So they are more seated and more in a stasis position. So they get stasis as well. And then they get all of this hypercoagulable state as well. So they are most likely to develop thrombosis. So in case in the SEQs, they ask for the pathophysiology of thrombosis, you can write all of that. So then in that you have,
Naveen,
yeah,
please again explain how the liver affects in this thrombosis.
yeah, that is what they say is it's not fully understood, but what they say is that because albumin levels reduces, that the liver tries to produce more proteins. So when that occurs, that the liver is now clotting factors are also proteins now. So then because of that, the overturn of clotting factors increases. So you can obviously ask that if anti-clotting factors are being lost in the urine, aren't clotting factors also lost? It is lost. Okay, so clotting factors are also lost, anti-clotting factors are also lost. But they say that there is an imbalance that is created, that because there are more anti-clot factors like antithrombin 3 that are lost in the urine, and because albumin is also lost, then the liver tries to produce more proteins. They also produce a lot of clotting factors, and because of that, the clotting factors increases. And in addition to that, because there is a state of hypovolemia, then within the blood vessels, the concentration of these clotting factors increases. So because of that imbalance, they get thrombosis. Is it understood?
Yeah. Thank you.
Yeah. Okay. Then they can develop DVT. So ask about the symptoms about DVT. Renal vein thrombosis. Main thing you can ask is about lung pain, gross hematuria, and abdominal pain. Then mesenteric vein thrombosis. You can ask about abdominal pain and abdominal pain after meals. Those are some things you can ask about that. Then moving on to what has been done so far. That is the last part of that history of presenting complaint. You ask about whether the mother knows whether what to ask, so what are the blood investigations were done, what the urine investigations were done, and was there a renal biopsy plan depending on the symptoms of the patient, and whether they have started steroid therapy. And you have to ask a lot of questions about steroid therapy, which will come to. Then remember also in pediatrics, most of these parents are very well educated and they know all of these things. So do ask these, okay, tell the names and ask whether they know what these things are. Then let's now move on to a patient who is diagnosed with nephrotic syndrome, coming with a relapse. Okay. Now in this instance, again, it's the same way that you would start. You will start with the current presentation. So in your presenting complaint, you can say this is a known child with nephrotic syndrome, currently coming with generalized edema for progressive generalized edema for 2 years, for 3 days duration, associated with proteinuria or whatever, or proteinuria. If the mother says that she knows it's protein, you can directly say with proteinuria for this many days duration. Okay, so that will be your history of your presenting complaint. Then with the history of presenting complaint, you will say the child was in his usual length, usual health till 4 days ago, when the child developed what a gradual onset edema first appearing in the face and then progressively but extending to his abdomen, scrotum, feet, like that you go. Okay, so again you start with the current presentation even if it's a relapse. So don't start with the initial presentation when it's a relapse. Okay, talk about what is happening now and then go to the first presentation. So then there you will talk about again same thing. So all of these are the same things. Okay, how was the what was the edema, duration, is the symptoms, all of that you talk about that. And then when it comes to the complications, you will ask about what has been done. You will ask about how was the relapse confirmed. These are just additional things to what was already discussed. Huh? That part is the same. It's just the additional things that come here. Then at the end, you will say how the child is now, but I usually like to say this part is that what the current status of this child is at the end of the presenting complaint. Okay, after you finish, sorry, at the end of the history of presenting complaint, now how the child is, and is the child well, is the child eating, has the child passed, these are things you can ask always. Is the child doing well generally? Does the child have fever? If it's a fever case, then if the is the child eating well? Has a child passed urine, and has a child gone to the toilet? Those are questions you can ask from all the patients at the end of your history of presenting complaint, just to give a view of the child at that point and what are the symptoms the child has at the time of history taking. Okay, then after you finish the current presentation, then you can go to the first presentation. So first presentation is you ask when at what age was the child got the first presentation. That will give you an idea of whether this is you're talking about typical or any typical features of the nephrotic syndrome. Then what are the presenting features at that time? How was that diagnosis made and what was the response of prednisolone at that time? Then you describe the progression of nephrotic syndrome over that time. So then after that, you ask about how many relapses that the patient had. What was the usual frequency of that relapse? Okay, this you need because you need to classify your disease at the end of the history. Then you have to ask what was the gap between the relapses, what did the patient do with the relapses. In the relapses, you don't need to ask details about the relapses. Okay, again, your details are focused on mainly in the first current presentation and the first presentation. Then you're asking about the relapses, just ask about when were the relapses, how many relapses, and what was done during those relapses. That is enough. Okay. Another thing is, remember that some of these patients will get transient proteinuria and they get admitted for transient proteinuria also sometimes. Okay, so it is always good to clarify whether this is transient proteinuria or whether this is proteinuria. So ask how much of protein was there. Okay, if a transient proteinuria, it should not be nephrotic range proteinuria, and you should not have any edema and things associated with it. In my case, I think my patient had the patient had 6 episodes of transient proteinuria and only 2 or 3 relapses. So my diagnosis was steroid-dependent nephrotic syndrome with but infrequently relapsing steroid-dependent nephrotic syndrome. So if you did, and thankfully my mother, my patient's mother knew that it was transient proteinuria. So she told me herself that the episodes were transient proteinuria. So because then if you get that wrong, then your classification of whether it's infrequently relapsing or frequently relapsing will be wrong. No? So then if you wrongly classify it, then your diagnosis is also wrong. No? So then always be clear to say whether this is a actual relapse episode that the mother got admitted with, the patient got admitted with, or whether it was a transient proteinuria. Only then can you differentiate between whether it's an infrequently relapsing or frequently relapsing. Okay, I hope that was understood. Then again, ask for the secondary causes here, nephrotic syndrome, especially now since the patient is having, if the patient has a lot of relapses and those relapses are a bit complicated, then you can ask about these things. Okay, again, complications is the same thing. Then management, now here you might have to go through details because you know that if it's a relapse, then the patient would have had different medications, right? So you have to ask about all of those medications, especially initially ask about steroids. Then when it comes to steroids, ask about the side effects of steroids. When the side effects, ask what the dose the patient is taking. Ask who is giving the steroid medications. Is the patient compliant with the medications? Then does the child like to take, you have to ask those things also. Now, is the child comfortable with taking the medications? Does the child like to take the medications? Then with the steroids, you know the side effects of steroids, and so you have to make sure you cover all of those side effects. Does they have any GIDs disturbances? Any growth disturbances? Then all of those, remember the side effects are all there in this note. If I don't get time to finish that, just go through that. Okay, you have to ask about all the side effects. Then ask how the dose is changed. Okay, that is also important. So was the complete dose given, and was it for how long was that particular dose given, because we know that for you to classify whether it's steroid dependent or whether it was a steroid sensitive or steroid resistant, for all of those things you need to know whether the next relapse came after finishing the steroid doses, or whether that relapse came while the patient was on every other day steroid doses, or whether it was after he completed the steroid therapy. All of that you need in order to classify it whether it's sensitive, dependent, or resistant. So those things you need to ask in the history as well. Okay, so those are some things that they will look for, in the sense that when did the child develop the first relapse? Was the first relapse while the child was still on steroid every day, or whether the child was got the relapse while the child was on every other day, or whether it was after he completed the complete treatment? Okay, so that is something you need to ask. Then ask whether how the doses have changed. Have the doses increased over time, or have there been any changes in the doses? Then what are the other things that the child has been started on? Okay, if it is non steroid sparing agents, like what are the second line drugs, like Masol, was there tacrolimus, cyclosporin, was the cyclophosphamide started? So if the child was ever given cyclophosphamide, then you should know that they give it usually in LRH. They don't give it nowadays. They have to go to transfer to Maharagama, and Maharagama only they give cyclophosphamide. So that is an injection that they give, and it's given in cycles. So they will usually know why they are giving cyclophosphamide. Okay, so cyclophosphamide is only given if it goes into end stage and the biopsy is showing some crescent formation or something like that. So then in cyclophosphamide, you have to ask about whether the person was hydrated before that. Was Mesna given? Was there any side effect specific to cyclophosphamide? So for all of those drugs, you need to ask all of those questions. Okay, what was done specifically, and what are the side effects that the patient developed for each of those drugs. So you need to memorize the side effects for all of those drugs. Then another important point is the vaccines. So vaccines, remember that when you're going into the vaccination history, you can add that. Okay, and there, remember that these are some things that they will look for. Okay, so I got Randula sir. So if you also get nephrotic syndrome and Randula sir, then sir will expect all of that now, because I remember when we were doing the appointment, he said that if you miss something like the immunization history, then that also they will think of repeating. Okay, so don't because it's very important now, because in nephrotic syndrome. So ask them what vaccine have they taken. Have they taken the pneumococcal vaccine? Another one is the varicella vaccine. These two they will ask. Okay, so in these two you have to also ask, was varicella, when was it given? Now if the patient is on steroids, or if the patient is on any other immunosuppressive medication, we know that you can't give varicella at that time, right? Because varicella has to be given. Varicella is a live vaccine. So when you give it when there is an immunosuppressive state, then we don't give it because it's a live vaccine, because that can develop into certain infections. So we don't give it at that point. We have to give it later. So you need to ask about that. Okay, specifically they will ask you, when can you stop those medications to give varicella? So if the patient was given other vaccines, now in the normal immunization history you're taking, in that also we know that there are certain live vaccines and certain kill vaccines. So in those live vaccines, like MMR, was MMR given while the child was still taking steroids? That is something you have to detect. In case the child was given MMR while the child was on steroids, and if you have missed that, then that's a big thing. Okay, so make sure you ask in the vaccination history when all of those vaccines were given, and specifically those live vaccines, was it given when the child was on steroids, or was it given after it stopped? If it was given after it was stopped, how long after it was stopped was it given? Okay, those things also asked. Then this is your clinic follow-up. Then urine protein testing at home is another thing you need to ask. You need to make sure that the mother is educated as to how to do it. And if you find that the mother is not educated in anything, okay, in your history taking, you find mother is not educated about something, in your presenting, always say that I inquired about the let's say protein testing. I inquired about the protein testing from the mother. However, the mother was not aware of how to do it exactly, or I found out that the mother has certain errors in her interpretation of the protein testing. Thus, I educated her as to how to do it properly. Okay, when you say that, then it gives a good impression that you have used your history taking time even at an exam to educate the mother. So that's a good thing. Okay, so always say those kind of things. Do it and say it. Okay, when you get time. Then other one is the normal pattern of history taking about the other parts. Was that thing okay? The history.
Yes, sorry.
Yeah. Okay. I'm trying to go fast. I'm really sorry. Then
Naveen, just
yeah,
one question. Like
yeah.
when we're asking about the vaccination, like should we ask about all the live vaccines, whether they were given while on steroids or
Yeah,
only
yeah,
the
yeah.
varicella?
That you have to, because you sometimes you don't know even the usual, if they are on their usual dose, or sorry, the usual vaccination will happen anyways. Additionally, only we are giving pneumococcal and varicella. But if their usual vaccine, they are not, even that they have to abide according to whether they are on steroids or not. So you can't give MMR. If it's MMR is given, you can't give MMR while the child is on steroids. So that will have to be delayed. So you have to ask whether that was delayed, because this problem happened in while we were doing pediatrics. Also, there was one patient who had got MMR while on steroids, so that was an issue. So sir was annoyed that we didn't pick it up while doing the taking the history.
Okay, right. Thank you.
Okay, okay. Uh, Yeah, this is the same thing. I'm just going to skip through this because these are common stuff. Then I'll just go through examination quickly. So in examination, always do anthropometry, height, weight, BS, body surface area, all of that. Okay, you have to look at the body surface area. Okay, so remember, don't forget nephrotic syndrome case. Use the nomogram. The nomogram will be there. You don't have to calculate it. Look at the nomogram and calculate the body surface area, or just ask some other. She will know mostly likely. Then distribution. When you're doing your examination, also tell this nicely, the how it has been distributed, if there is edema now or not. Check the sacral area, because most of these kids are going to lie down. So check the sacral area if there is, depending on the age. Then look for rashes for secondary causes, and look for the complications that you asked in the history, cellulitis, DVT, and also all your side effects. Okay, all use drugs, there are different side effects now, so look at those cushingoid features and all of that as well. Especially if the child is on tacrolimus, or if the child is more than tacrolimus, the child is on calcineurin inhibitors like cyclosporine, then the patient might have a lot of hair. Okay, they get this they get this hair growth, excessive hair growth. So those are questions, things you can check in your examination as well. And then this, steroid toxicity, like I said, check for the Cushingoid features. I'm going to go through that. Check for the blood pressure. Make sure that you interpret the blood pressure according to check the charts before going for the exam. Properly see how to interpret blood pressure based on their height. Okay, so do that when you go there, and check whether it is, usually what I do when I check this is, because it takes a lot of time to check with the height, I just check the blood pressure and see whether that is below the 90th centile or not. So if it's below the 90th centile, I know this child doesn't have hypertension, so I can just say that the blood pressure was checked, it was below the 90th centile for that age. Okay, sometimes you can, if you don't know the height and want to check the height centile, you can just do that. Then check whether the cataract, these things remember to ask in the history as well. Okay, then yeah, all of this is okay. Then in the abdomen, like I said, check for edema, pre-fluid in the abdomen. Check for the shifting dullness, if you can, and if the patient's age is appropriate. Then look for, sorry, epigastric tenderness and all these tenderness as well, because especially if they have some thrombosis that is associated, they might have this tenderness. Yeah. Then this one, okay, look for the abdominal wall edema. That is something that they ask whether the patient has abdominal wall edema. This it's actually with crepitus that they find out whether there is abdominal wall edema or not. That you have to touch the abdomen and see, and whether there is crepitus in the abdominal wall. So with that, you can find out whether the patient has abdominal wall edema or not. If you can look for genital edema and measure the abdominal girth if you can. Okay, that is also good to go with. Then check the pulse, the capillary refill time. Measure the blood pressure, like I said, because we know if the patient has hypotension, then it is because of hypovolemia. If it is hypertension, then there can be different causes for that. Since this thing, nephrotic syndrome, I don't think they will give you a child with hypertension. But if they do, just think that it can be due to drug effects or because of certain hypovolemia, that the patient has got a vasoconstrictive response as reactive. So it's a reactive hypertension. Okay, to overcome the hypovolemia, the patient has vessels have been constricted, and because of that, the patient's blood pressure has increased. Okay, or maybe some other dual pathology, which is they're not going to give. Then check for pleural effusions if the patient has developed pleural effusions. Then remember to check for cataract. Okay, if the patient has cataract, if you have time, and then other things you can just quickly do, because most of the time you won't have time. Just do this quickly. Okay. Yeah. Then, so that is the examination. Then I'll move on to the management. So when it comes to nephrotic syndrome, what is nephrotic syndrome? These are the definitions. Remember, memorize this and go. In the sense that, so this is from Randulas's book itself. So proteinuria 3 plus in the first morning urine. Okay, this is nephrotic range urine, and then these are the values that they have given. I think there are different values for different cutoffs, but this one is the cutoff that was given in Randulas's book itself. So use these cutoffs, it's okay. Okay. So yeah. Then if the plasma, so we know that nephrotic syndrome has 4 components. One is the proteinuria, nephrotic range proteinuria, then hypoalbuminemia, that is your low plasma albumin, then edema, and hyperlipidemia. Hyperlipidemia is mainly they check serum cholesterol. Okay, total cholesterol is what you need to do. So total cholesterol is more than 250 milligrams per deciliter, means you can diagnose nephrotic syndrome with all of these. Okay, and to diagnose it, you need to have 3 out of 4. And then you can diagnose. Then what are the investigations you're going to do? Then when it comes to investigations, remember you're going to look at the UFR. So in the UFR, you're going to look at the pus cells and the red cells, and you can look at the albumin in the UFR, and you can check for your highline cast. So in what are, if they ask you what are the casts that can be found in nephrotic syndrome, it is the highline cast. Okay, not usually find highline casts are usually found. And then instead of that, you can do your urine ward test as well, that you know how to do. Then remember, if it's a presentation there, you're going to always do urine culture and ABST to rule out any urinary tract infections. Then you're going to check for the serum albumin, the serum cholesterol. You can just do, just without saying lipid profile. Most people like to do just like it if you only say the serum total cholesterol, but some people prefer when you say lipid profile, but it depends on the examiner, but you can say serum total cholesterol or total lipid profile. If they say, do you need to do the lipid profile for everything, then you can say no, specifically we need the serum total cholesterol, that's what we need. Okay, then you can do the urine protein creatinine ratio as well, like I said here, and this is the value to interpret that. Okay, then this is just a recap about proteinuria. Like I said before, transient proteinuria, that will be associated with fever, dehydration, exercise. So like I said, that does not go up to nephrotic range, it is +2, and they will be repeated. It's normal when you keep daily repeating it, it will become normal after that. Okay. Then orthostatic is a protein increased when your patient is upright. Okay, that you can just know that. Then we have this proteinuria, which is your renal disease. But remember, proteinuria can be glomerular or tubular disease as well. Both can cause. Tubular disease has a different type of protein, which you don't need to know. Okay. Then another one is this. What are these atypical features? If the if this patient has, wait. Before coming there, we'll go this. Then other investigations are, what are the other investigations you're going to do? This, you can do this, not always important, but if the patient has recurrent relapses, and if this is some atypical symptoms are there, then you can do renal function test and serum electrolytes. Otherwise you don't need. Sorry. Now these are, if you're going to do ESR, ANA, Hep surface antigen, and serum complement levels, these are for your secondary causes. Okay, so if you want to diagnose something other causes, and if you're suspecting a secondary pathology that is causing nephrotic syndrome, you have to order these investigations. Okay, then when it comes to renal biopsy, now renal biopsy, remember these. Now these are the boxes I was talking about in concise. Okay, so these boxes, there are several boxes like this. Remember to study these boxes. So what are the indications for renal biopsy? So there is steroid resistance, whether it is primary or secondary, if the patient is steroid resistant. Okay, so remember, if there is steroid dependence with frequently relapsing or infrequently relapsing, then you don't need renal biopsy. So even in my long case, sir asked me, are you going to do a renal? Now this patient has had 6 episodes of transient proteinuria. He has had infrequently relapsing steroid dependent nephrotic syndrome, and currently has just come with a relapse. So he asked, and he was on levimazole and was on tacrolimus. Okay, all those drugs. Then so asked, are you going to do renal biopsy? But if you go through these indications, there is nothing to say that this child has renal needs a renal biopsy at this stage. So I said no, but the child, there is no indication for this child to do renal biopsy at this stage, unless the child develops steroid resistance as it goes. This child does not need renal biopsy at this stage. Okay, and if the, so look at, so just because there are a lot of other things that are there in that doesn't necessarily mean that you need to do renal biopsy, unless these features are there. So the other thing is if the child is less than 6 months, and if there are features of secondary causes, if there is deranged renal functions, which is not attributable to hypovolemia. What that means is that we know that when the child's when they develop hypovolemia, anyway the renal functions are going to get deranged now, because they get dehydrated and the renal perfusion is reduced and the serum creatinine will increase. So you can't use that when the child is hypovolemic, but otherwise you can use if the functions are deranged, you can do a renal biopsy. Then if there is persistent microscopic hematuria with hypertension, if there is macroscopic hematuria, and if the complement levels are low. Okay, so these are the only indications to do renal biopsy in a child with nephrotic syndrome. Remember this. Okay, make sure that you are thorough with these indications, because if they give you a complicated case with so many drugs and all, and you might think the patient needs renal biopsy, but there is no indication. Okay. Then the other thing they will ask you about is renal biopsy preparation. Other one I want just to tell you that these are also the atypical features. Okay, so if you look at here, I have put a small listing. Just go through this later. What are the atypical features of nephrotic syndrome? That will be mostly similar to your indications for the renal biopsy. So read that and see. And if there are atypical features, then you can do these investigations, like I said before. So then what to do about renal biopsy. So I have put a note about renal biopsy. Just go through that. So it can be done. They might ask you about the details about renal biopsy. So it can be done by either nephrologist or an interventional radiologist. The nephrologist has to do an ultrasound scan prior to the procedure, locate the kidney. But an interventional radiologist, they usually do real-time ultrasound scan guided renal biopsies. Okay. So remember that the surgical team does not do the renal biopsy. They are only play a role in after that in managing the complications. So steps are: you take written informed consent, then pre-op investigations, you're looking for any clotting or bleeding tendencies, because it is an invasive procedure and you might expect the patient to bleed. So you have to do clotting profile, you do PTI, NR and APTT. You need to know the baseline hemoglobin, because this is a risk, because I said there can be a bleeding, there can be a procedure with a high amount of bleeding. Check the baseline hemoglobin, and if the patient has a hemoglobin of more than 10, okay, we prefer to go for biopsy if there's a baseline hemoglobin of more than 10. And look at the platelet count. If it is less than 100,000, then they might not postpone the procedure. Then blood grouping and DT. Okay, keep 1 unit of blood ready before the procedure. Then other one is you to do ultrasound scan, because we want to check if the patient has 2 kidneys and what their sizes are. If the child has gone into CKD and the child end stage and the kidneys are too small, then we won't do, because anyway if you take the biopsy, it's not going to be birth. You're not going to look at anything. It'll only be fibrous glomeruli, so that is not going to help you. And also if the kidneys are very shrunken and small, there is a higher risk of damaging the surrounding structures, so you're not going to do it. If there is only 1 kidney, again, because there's a risk, you will try to postpone it. You won't do the biopsy. Okay, you might do it, but you will be more cautious. Then other things to do is, so remember informed consent, pre-op investigations, then referrals, or you need to inform these people, your radiologist, the interventional radiology team, anesthesiologist, because they will need general anesthesia. If the child is bigger, more than 12 years, then you can do local anesthesia, but usually it's done on general anesthesia. And you have to also inform the surgical team, because if there are complications that develop during the surgery, then you will have to call the vascular surgical team to come and intervene. And then you should also inform the theater. So you have to keep the patient fasting for general anesthesia, so 6 hours for solids and 2 hours for clear liquids. And the biopsy is usually performed in the morning at 8 a.m. Then make sure to hydrate the child, because the child is fasting. So maintenance, you give the maintenance dose of 0.9% sodium chloride and 5% dextrose. Calculate the quantity Sega. Then the specimens. So specimens you have to request from MRI and LRH, the pathology lab, to get the sample bottles and request forms from them, and they will send it to you, and then only you can do the procedure. Okay, so you have to send 2 samples, one for histopathology, that is in 10% formalin, that you have to send to LRH, and the immunofluorescence you have to send it in saline, and that should be covered in ice, and that should be sent to MRI. So remember, a good sample of if you take a biopsy, the good sample should have at least 10 glomeruli. Okay, so if it is less than 10, then you consider that as an inadequate sample. However, you always, no need to repeat always, it depends on the consultant to decide. Okay, but you need to have at least 10 glomeruli. Then prior to the procedure, it's good to check the urine color, and you want to make sure that it's clear, because post procedure you need to monitor the urine. Okay, then you have to get sandbags, and if there is asthmatic patient, you need to wheeze. These are normal things. Okay, then after the procedure, make sure that the patient is nil by mouth until full recovery. Make sure patient gets strict bed rest for at least 24 hours in the prone position. That is because so that prone position, and after the biopsy, sorry, so there might be a development of clot. So if the patient moves a lot, then that clot can get dislodged and then there can be more bleeding. That is why we ask them to take strict bed rest for the next 24 hours. Okay, one is for that, and the other one is to prevent any hematoma from forming. So following the procedure, these are the things we monitor as usual. Because the patient is getting general anesthesia, we need to monitor these things. Then we are looking for any abdominal pain, tenderness, distension, and we're looking for the color of the urine. Okay, so any child can have some hematuria up to the 24 hours. So you have to be aware if there is fresh blood in the urine after 24 hours. Okay, and if there is any alteration in their other parameters, that is your blood pressure, your respiratory rate, pulse rate, and all of that, because that might also indicate that there is some internal bleeding that is going on. Then you need to keep you need to keep under KUO, okay, for hematuria, keep under observation for hematuria in consecutive bottles for at least 4 times. That is, you take 4 bottles and those small penicillin bottles, okay, you collect for 4 and see whether the child is passing any urine. So if it is clear after that and over 24 hours, then you can say that the child is okay. Okay, so this is just a post-op analgesia. These are the complications that the patient can develop. Just read through it. I'm trying to go fast. Then contraindications are if the child has any bleeding, that this is an uncontrolled severe hypertension. These are the 2 main contraindications. There are a lot, but if you know these 2 mainly, that should be enough. Okay.
Naveen, man.
Yeah.
When you are taking that urine samples,
Yeah.
are we taking them like when child wants to pass urine?
Yeah. When the child wants to pass you.
And what's the reason to bring sandbags to the theater?
That is to position the child, because you need to make sure you put one. If you the child will be sleeping on the left lateral position, so then you need to put a sandbag down so that the position of the child is adequate. That's why we bring the sandbags down. It's just to position the child.
Oh.
Okay, nothing fancy.
I mean, like when you're saying strict bed rest, aren't we allowing them to go into the washroom, or is it
You can no. They do it from there itself. No,
Uh-huh.
you take the urine sample from the bed itself. As in, you can get the child to get up and pass urine, but not to move around a lot is what they mean.
Right.
Okay. Okay. So then this is another thing that they will ask. So sir asked me also what. So I said that you don't need to do the renal biopsy. Then, but anyway, sir asked me. Let's say you do a renal biopsy in the future, and then what will you expect to see in the renal biopsy? Okay. So that is something they will ask. So that you should know something about the pathology in the sense that what is the majority of the type of disease that they will get. We know it's mainly minimal change disease. So what will you see in minimal change disease? You will see nothing. Okay. In your light microscopy, you won't see anything, but in the electron microscopy, you can see podocyte effacement. We don't have electron microscopy, so you don't need to say that, but if you can say that, if you know that, it's good. Okay, so that is minimal change disease, what will be there most of the time. Then you can have focal segmental glomerular sclerosis, you can have membranous glomerular nephritis, and mesenteric proliferative and IgA nephropathy are some other causes which they won't ask mainly. They will mainly ask about minimal change disease, but there are different definitions for this. I can't remember the details. If you want, just go and check that. Then secondary causes, like I said before, these are the things with secondary causes. Okay, so they will mainly ask about minimal change disease. So just know that mainly that on light microscopy you won't see anything, and in electron microscopy you will see podocyte effacement. Then when it comes to management, so this I think there is a lot of reading also that you have to do in terms of management, because I won't be able to cover everything. I'll just give you the topics, okay, as to what to study mainly and give the important points. If you have any questions, you can ask me. Okay, so what you need to know is in the diet. Okay, how are you going to give diet? So diet is mainly in this, what I want you to tell is they have to have adequate energy requirement should be there. Then protein requirements, you should give a normal protein diet in these children. That is another thing you need to ask in the history, in the dietary history, ask about whether the mother has any misconceptions about protein. Okay, so those things you need to ask in the history as well, in the dietary history part. Then lipid, this you need to talk. You can restrict the trans fatty acids and all those things. The deep fried stuff can be you can restrict them. Then salt. Remember, initially you restrict the salt only when the child is in the edema episode. Once the edema is resolved, you can give salt. Okay, so salt is only restricted during that edema episode. That is why we don't want to give salt. Then fluid is not restricted, so we give fluid as normal as possible, because then the other general management, like I said, this you talk about all of these, maintaining the charts. Okay, now charts is something they will ask. What are the charts you're going to maintain? So in that, so the charts, what are you going to maintain? Just tell that you're going to maintain a BP chart, then the daily, the protein urine ward test chart, then your daily weight chart, then the input output chart, then your abdominal girth chart and temperature chart. Okay, those are the charts you're going to maintain. So make sure you know what are the charts to maintain in this child. Then other thing is you're going to start this patient on prednisone steroid therapy. Before that, I'll just say these antibiotics we give, this prophylactic antibiotic, oral antibiotic, we give penicillin 250 milligrams BD for 10 days. Those is something that we give because, like I said, in the protein urine phase, sometimes there can be this thing. At the same time, we want to cover for the other part as well. Okay. Then we give come to this later. Furosemide. If you're going to give gross edema, you're going to give diuretics, then you have to give furosemide. But remember, when you're giving furosemide, you can't give furosemide alone. Okay, you have to always give it with conjunction with albumin. And also remember that albumin delivers the furosemide better when you give it. Furosemide is delivered better to the renal tubules when you give it with albumin. So we don't give furosemide alone in nephrotic syndrome. We have to give it with albumin because remember they're already a hypovolemic state. Okay, that is why it's good to know the pathophysiology, because in nephrotic syndrome, like I said, it's hypovolemic state. You give furosemide, the blood pressure will reduce even further and the child will go into hypovolemic shock or whatever. So that's why we don't give furosemide alone. Okay, you have to give it with albumin because we know albumin acts as a colloid. So the intravascular compartment is filled with some fluid when you're giving it with albumin. And also delivery to the renal tubules is better with albumin when you give it with, for furosemide when you give it with albumin. Then steroid therapy, we know the dose is 60 milligram per meter square per day. So then we give that as a single days in the morning. I'll just tell you where that what to study. So here this is the this thing. Okay, how we give prednisolone is there here. I don't think there's time to go through in detail. Just I'll tell you what to study. Okay, so study this part when it comes to prednisolone as to how to give it and how we are going to divide these doses. Initially we give 60 and then 40. Yeah.
Our gin and spec postponed, which was on 7 to 8. If others are okay, you can take your time and do the best.
Okay. So can others tell if you're okay? Or what do I do? I won't take all 2 hours. I'll just try and finish this soon. I'll anyway just tell you what to study because ultimately you all also have to study neither. So I'll just go through this quickly so that you all can just look at this. So what I want to say here is mainly the 60 milligram per meter square is given for the first 28 days, and then you give 60 milligram every other day for 2 weeks. Okay, and then you reduce every other day dose every 2 weeks. So that every 2 weeks, how you reduce it is what is given here. So initially 60 every other day for 2 weeks, then 40 every other day for 2 weeks, 30 every other day for 2 weeks, 20, like that. Okay, so this is a pattern that is given after that, and you taper that over 12 weeks. So if you add all of this, you get 12 weeks. 1, 2, 3, 4, 5, 6. Yeah. Then, so total duration with addition to the initial 4 weeks, you will get 16 weeks. Okay. So that is the way you give prednisolone. So what they say is when you're treating with these patients and the patient goes into remission within the first 14 days of this initial 28 days, then you consider patient an early responder. Okay. So if the patient does not go into this 14 days, then you know that that person may not most likely respond. So that's why they go for a nephrology opinion. Within those 14 days, if the patient doesn't respond, then we know that this patient is most likely not to respond, even though it is not within that 28 days. So you think that the patient won't respond and you go for a nephrology opinion. This you don't need to know. Okay. Then you can give this about how you give the doses. Okay, so this you should be given as a single morning dose after meals, and usually they give it with omeprazole also if the patient has GI disturbances. Then like gastritis, you can round it up to the nearest 2.5 milligrams, and dose should not exceed more than 80 milligrams per day. You can give that in 2 divided dosage, that is morning and evening. You don't give it at night for those having difficulty in tolerating this high dose. So when you're doing that, you give 2/3 of the dose in the morning and 1/3 in the evening. Okay, so this is the main management of nephrotic syndrome in terms of the prednisolone dose and how you give the steroids. Okay. Then when it comes to Okay, at this point itself, I will just tell this also. Again, when it comes to this nephrotic syndrome, the definitions. Okay, so this is concise. Like I said, remember to study these boxes. Okay, so concise, it will tell you what are the definitions of this remission, relapse, what is steroid sensitive nephrotic syndrome, what is a frequent relapse, what is an infrequent relapse, what is steroid dependence, and what is steroid resistance. So if you look at remission, that is when you have started steroid therapy and the patient goes into remission. So that is urinary protein excretion is negative or trace for protein for 3 consecutive days. Okay, so when this happens, you can tell that the patient has gone into remission. Then relapse is when there is urinary protein excretion plus 3 or more for 3 consecutive days and or edema in a patient who has been in remission. Okay, the patient who has been in remission develops proteinuria for 3 consecutive days plus 3 or more. And also if there is if there is less proteinuria but the patient has developed edema, then you have to ask the patient to go to the hospital because that can be an indication of a relapse. Okay, then the one is any amount of proteinuria with edema, that also we take that now. Yeah, then steroid sensitive nephrotic syndrome, that is the ability to achieve remission within the 28 days. So remember, the cutoff is 28 days, even though we say early responder is 14 days and that they are less likely to respond after 48 days. In terms of definition, we have to take the 28 days. Okay, so the ability to achieve remission within 28 days of treatment with prednisolone, that's 60 milligram per meter square. Then you have the frequent relapser, that is occurrence of 2 or more relapses within the first 6 months or 4 or more relapses within any 12-month period. So this thing you need to know. Okay, these are some things that you might forget when you go for the exam. So just look at those things before the exam, before the long case. Remember to see these definitions and go so that you remember it, because you have to classify the diagnosis of your patient at the end of your case. Then infrequently relapser is someone who has less than 2 relapses within the first 6 months or less than 4 relapses within any 12-month period. Okay, so it's the opposite of the frequent relapses. Same thing. Then steroid dependence is occurrence of 2 consecutive relapses while on the alternate day prednisolone or within 14 days of the cessation of the alternating day of the prednisolone or cessation of the prednisolone. Sorry. So this is why I said it is important to ask when the patient developed the relapse. Okay, because in order to classify what of these things are that your patient has, you need to know when the patient got the relapse, while it was on prednisolone, while it was on alternative day prednisolone, like that. Then failure to achieve remission despite 28 days of prednisolone at 60 milligram is your steroid resistance. That means this is when the patient is taking it every day. When the patient is taking it every day for the first 28 days and the patient never develops remission, then we call that steroid resistance. But steroid dependence is he has completed that 28 days, but after that he is taking, he gets 2 relapses while he is taking that alternate day prednisolone, okay, or within 14 days of cessation. So these are the definitions for that, which you need to memorize. Okay, these definitions you need to know, yeah, when you go for your case. So then moving on to the next part is the edema management. If there is mild edema, you don't need to, you can give a normal diet with no added salt. Okay, so but what we usually say is edema, it might be difficult for you to classify what is mild, moderate and significant gross edema. So for that you just say when the patient has edema, at that point we don't give salt. Okay, we do salt restriction. But this is a moderate edema. You can say if there is the dosage for those things is we can give oral furosemide and spironolactone can be added. Now these things I don't think you really need to know in detail. Okay, with terms of how to give for everything, just know that when there is gross edema, you can do fluid restriction at that point with 70% of maintenance, because I said usually we don't do fluid restriction because the children are on hypovolemic state. But if you know that there is gross edema without any hypovolemia, then you can give a fluid restriction for 70% of the maintenance. Okay, then you can consider high dose of diuretics, but we usually give albumin with diuretics. But in this guideline, it says that if the child has with hypovolemia, then you can give only albumin. Okay, so other thing is, this is what I said before in terms of, because we are dealing with hypovolemia now, I'll tell you the features of hypovolemia. That is, you can have cramping abdominal pain made worse with meals. That is, you get this pain because if hypovolemia means there's reduced perfusion to these organs. So if there's reduced perfusion to these organs, then they get this pain. Ischemic pain, that is what they get. Then they can get partial hypertension, dizziness, lassitude, urine output can be reduced. They can get tachycardia, that is because a reflex tachycardia that they get, pulse volume will be low, cold peripheries, prolonged capillary refill time, pulse pressure can be narrow, followed by low blood pulse pressure. Initially, pulse pressure is narrow because of the reflex reaction that occurs. Then they will develop into the low blood pressure. Then they can go into circulatory failure or shock, and your hematocrit can be raised because there is hypovolemia. You get a high amount of concentration will increase. Then reduced fractional excretion of sodium is what you get with pre-renal AKIs. Okay. Then yeah, here what else I want to say is the management of this shock. Okay. So then moving on to the management of shock, that is nephrotic syndrome, the patients who come with shock. In this, what you need to remember, this is the CLD that we had, this note. Okay. So this is good. This is actually Randhur's management. So just know this. That is, if the patient is hemodynamically unstable and patient is in shock, that is because of hypoalbuminemia, where there is a fluid shift from the intravascular space to the extravascular space. So how are we going to manage? Do the initial ABC management, then give 0.9% sodium chloride. We give 20 milliliters per kilogram bolus, and then you monitor the pulse rate and the blood pressure. And remember, it's always crystalloids that we start with when the patient is hemodynamically unstable. Okay, and they're coming with shock. It's not the same as hypovolemia. Hypovolemia is also this what leads to shock, but this is currently we are talking about the management of shock. Okay. Then first and then only you give albumin. As colloids, due to their high molecular weight, they can't open up the small microvasculature. So in order to initially open up the small microvasculature, we give this crystalloid, which is 0.9% sodium chloride, 20 milligrams per kilogram bolus. If there is no response, then we give the 5% albumin infusion, and you don't give a second bolus of crystalloids. So here the difference is we give first bolus of crystalloids to open up the microvasculature, and no response, then we give 5% albumin. Okay, so how are we going to give 5% albumin? We give 5% albumin 10 ml over kilogram. So that is because, okay, just know that. And that is to expand a little quicker as they are hemodynamically unstable. So if you have 5% albumin, you can give, or else if there is no 5% albumin, you need to know how to prepare the 5% albumin, which calculate it and see in the ward, because they usually have this 20% albumin now. So I think there's a sticker, this one. This is the one that they have in the ward usually, which is 20%. Okay. So then just know how do you convert this 20% into 5% albumin by how much of saline you need to add it to dilute it. Okay. Then if you're giving 20% albumin, that you can give over 4 hours. Okay. So when you're giving it over 4 hours, you can give that slowly, but you can't give that quickly. So you have to give it over more slowly. Just know that. And when you're giving this slowly over 4 hours, midway you give furosemide. Okay. But remember, like I said earlier, that furosemide is usually not recommended if the child is hemodynamically unstable. Then after you have done this initial management of someone who comes with shock and who is hemodynamically unstable, then you need to rule out any infections in this current relapse, like the usual management. Okay, that is also has said. Yeah.
Now in that 5% albumin, within how many hours you are going to
that is you have to give it quick. The didn't give a specific time, but you need to give it soon. So I think they just there is no specific time as such, but we give it quickly at that stage. So I don't exactly remember if there's a specific time to give it to, but what he said was you have to give it quickly.
And when you are giving it like 10 ml per kg, that then they mean dilute it in the saline and you give it like as a bolus.
Yeah.
Okay, thank you.
Okay. Because 5% albumin is usually not available in the body. If it is available, you can just give it. Don't need to dilute it. Just give it like that itself. Okay. Then the others are the same. Okay. About steroid therapy and all of that. Another thing that they might ask is this methylprednisolone. When can we use methylprednisolone instead of prednisolone? The thing with methylprednisolone is the compliance is better because the dose is less frequent, obviously. And also you have this problem is they get this, sorry, when they have gut edema also, sometimes absorption of prednisolone is less. Right, so that limits the absorption of your oral medications like prednisolone. But methylprednisolone is IV now, so then they can treatment thing is better. But so they usually use them in very small children and in edematous children, because when you're having edematous children, they assume that the patient has gut edema as well, so absorption is less, so they will give it as methylprednisolone IV doses. But there is some difference as to a conversion of methylprednisolone. I don't think they will ask that, so you don't in detail in that. Then the other was monitoring that I said earlier with all charts and the dietary advice. So just read all of these. Okay. Then the advisors, like I said before also while discussing the history. So how are you going to advise the patient? And the good thing to say is, one of the things most people be worried about is this. My patient also, I remember the mother was worried because I had so many transient proteinuria and relapses and all that. The mother was worried whether the child will go into end-stage renal failure, whether the child will get CKD. But you know that mostly it is what minimal change disease. So with minimal change disease, it's they don't go into CKD. That is something you can educate the child and educate the mother. Okay. Then you have to educate about the home management of nephrotic syndrome, what to do in a relapse, when to come to the hospital. Those things you need to tell. Okay, you need to educate the mother and you need to know that as well. Okay. Then in terms of in terms of education, you need to tell about what is the disease, why the child has got this disease, and explain the disease, the pathophysiology of disease in a very layman's term. Then tell, when you're explaining it, tell that it has a relapsing nature. Especially if it's the first episode, you need to tell this will come again. Okay, you have to tell that to the mother. Then it will take around 8 to 7 years for it to resolve completely, and it won't cause any kidney damage, like I said before, unless it is something else. Then you have to do frequent clinic visits. You need to have good compliance. You don't change the dose according to the way you want to. When you get infections, increase the dose and all of that. Don't tell them to do it. Okay, even though some places they say then to do it. When we were in our prof appointment, they told not to encourage patients to change the doses as they want. Always encourage them to come to the clinic, and there, if there is an infection or something, they will decide whether to increase the dose or not. Okay, or reduce the dose or not, either way. Then how you have to educate about the urine ward test as to how to do it and when to come to the hospital. That is, you come to the hospital when there is +3 for 3 consecutive days, that normal remission, this thing, or even if there is any amount of proteinuria with edema, you have to come to the hospital. And if there is reduction in your urine output, also you have to come to the hospital. Okay, those are the conditions where you have to come to the hospital. Then you have to educate about the diet, like I said. Until the edema part, don't put salt, and restrict the potassium levels. You can say that until the urine output is normal. If the urine output is reduced, then it's better to restrict the potassium levels as well. Okay, or else if the urine output is normal, then you can continue the normal potassium levels. But that diet history, remember this sodium salt restriction all is mainly in your ward setup. Okay, when they go home, we give the other dietary advices. That is, they are avoid refined sugar, avoid the deep fried foods and all of that, to avoid your fatty acid content. Those are the things you, and have normal protein amount, are the things you tell the patient when the mother is going home. Because at home we try to maintain a normal diet as possible. Okay. Then you have to tell about physical activity, make sure that the child is having normal physical activity. You need to educate about immunization vaccines, like I said. Then you have to make sure that the child has prevention from getting any infections. So for that, you can say, if the someone in your family has certain a cold or a cough or whatever, make sure the child doesn't sleep in the same family, something like that. Okay, don't give unrealistic advices where the mother won't be able to, the child won't be able to have a normal life. Like you can just say now, because if there is COVID pandemic or something like that, if there's an epidemic going on, the child can wear a mask if the child is old enough, or else you can avoid. But don't say advices like, I will not to send your child to school or something like that. Okay, don't say those things. Yeah, so that is in terms of this, mainly in terms of the education part. So this with the drugs, you have to educate about all the side effects of the drugs. I will skip this because most of you all know how to do this. So do you want to ask, do you want me to go through this again in detail about these things? But how to do the heat test? I'll know neither.
Yeah, heat test. I don't know that.
Okay. Yeah. Okay. Then remember that usually when you're taking this steroid therapy, we say no live vaccines after 3 months after stopping this steroid therapy. Okay. And the other one is that when you're taking tacrolimus or the other second line agents, it's usually that is a bit variant, but you can say about 6 months. Okay. If you say that, that's enough. Then these relapses I discussed with you all. Definitions I discussed. The second line agents. Now, second line agents, when to start when is something a bit. Before going to that, we'll talk about this. Will the management of complications. So I spoke about hypovolemic shock. I'm not going there again. Then peritonitis. What do we start? So we start antibiotics. We give IV benzoyl or IV cefotaxime, and for prevention is what we do this. Like I said before, and your vaccination. Then thromboembolism, if the patient develops thromboembolism, then only we give. We don't give prophylactically usually, but you can give if the patient has what heparin, and then you can continue with warfarin. Okay. So yeah, this was the one that I said. Okay, initially how that develops. Yeah. Mm. So these are the side effects of steroid therapy. Again, I'm not going into detail. Just read this. Make sure you know all the side effects of steroid therapies. Transserum proteinuria, I explain what transserum proteinuria is. In your history, make sure you remember to differentiate transserum proteinuria and a relapse. Then your second line drugs. Second line drugs, you don't need to know. The thing you need to know is the things that were asked from me. Okay, I'll just tell that. Now, my patient was on levamisole and was on tacrolimus. So, sir asked me, what is the mechanism? What is levamisole? What is the mechanism of action of levamisole? What are the side effects of levamisole? And what he asked, what is it? So he was expecting that it was an antihelmintic, and how does it act in nephrotic syndrome? So you need to know that all of these drugs have an immunomodulatory effect, right? They're either immunosuppressive or immunomodulatory. You can use both interchangeably, I think. So say that it has an immunomodulatory effect. So because the nephrotic syndrome has an immune component to it, this acts by modulating that immune function. That is enough. Okay, they also don't know the exact reason how it acts. No? But for others, for cyclosporin or tacrolimus, they are calcineurin inhibitors. So they act in a way that this calcineurin is you just tell it's calcineurin inhibitors because the way how it acts is a little bit complicated because they reduce synthesis of T cells and all of that, and that's how the calcineurin ultimately acts. But without going into details, just know how the name of these drugs and just the short mechanism of how they act. Another thing you need to know is that these are steroid sparing agents, so they are not steroids. You're giving them as second line agents. And what are those agents? What are the options you can give? How they are given? And what are the side effects? And if those side effects are there, how do you avoid those side effects? And what you should do to monitor those side effects. Like for cyclophosphamide, if you give IV cyclophosphamide, usually they would, because they have a risk of going into cytopenias, you do a full blood count during the first week. And then you have to also monitor because they can get the side effects like hemorrhagic cystitis. You do your you give mesna and you hydrate the patient before giving cyclophosphamide, and they can go into premature ovarian failure and stuff like that as well, which are something you can just discuss. Okay, they're not going to ask you so much in details for these things. Mycophenolate mofetil is something also they will ask. The important side effect here is this diarrhea. Okay, they get this gastrointestinal disturbance, and diarrhea is very important. We had a patient who came with this diarrhea and gastrointestinal disturbance with mycophenolate mofetil. It was started and this patient developed these symptoms. So this is symptom that they will ask. This is a very important symptom with this. Okay, mycophenolate mofetil. Other things are common for all of this is leukopenia. With levamisole, what you need to know is rashes. Okay, again leukopenia, blood dyscrasias, and rashes. That is for levamisole. Then, like I said, tacrolimus and this thing are cyclosporin are calcineurin inhibitors, and they affect the T cells. So how they affect it is you don't need to know. Then cyclosporin, know what are the side effects. Nephrotoxicity, hypertension can occur. Like I said, this hypertrichosis is the excessive hair that they grow. Okay, then gingival hypertrophy or something else. So now these things you need to know. They will ask, okay, because they asked in my long case also. So need to know what are the side effects, and it's not because you do well that they ask it. Sometimes they start they will ask even from the beginning. Like even Randula sir's first question for me was So what is levamisole? So it's not that they just because you do well that only they will ask you this. You can't say that. They will ask even when you start itself. They might ask these questions and start off. Okay. So this is what I said. Others when you give the live vaccines while on these medications. So this is also something they asked me. When will you give when the patient, because my patient was on tacrolimus, when will you give varicella once the patient is on tacrolimus, and when will you give it when the patient is on steroids? So those things also just know these. Okay. Uh, and also concise again has a good table with that. Yeah, here concise table is also good about this. It's very short and sweet and concise, so you can read this. This is enough. Okay, all of these for each of these drugs. Just remember to read concise in terms of the second line agents. Okay. This no need to know as to exactly how to start. I don't think they will ask this. Okay, you don't need to know. Just know the second line agents, and just to start the second line agents is usually the consultant's decision. Another important thing is that you give these AC inhibitors. AC inhibitors you can give because that is, it reduces, they are antiproteinuric drugs, so they reduce proteinuria. But when you're giving AC inhibitors, they are not given in the acute phase, because we know that again, nephrotic syndrome is a hypovolemic state. You give antihypertensive, the patient will go into more hypovolemia. So once the acute stage is finished and the patient has been more stable, is when we start this patient on AC inhibitors to reduce the proteinuria. Okay. Another thing you might have seen in the ward is also they give calcium to these patients, and that calcium is usually given for those with reduced albumin because they lose calcium with the albumin as well. So this we spoke about. In terms of management, so hypertension management, usually they won't ask with nephrotic syndrome, but with nephritic they will ask. So just go through these medications as to what to give. In nephritic, when you're studying nephritic, learn the hypertension management. Other test is a urine test. Diet I spoke about. Vaccination I spoke about. Hypertension, most likely they won't ask here. Uh, this I spoke about. Varicella infections, don't think they will ask. But if the child develops varicella infection while the child is getting immunosuppressive medications, then you have to treat with IV acyclovir as soon as possible. Okay. Then just read this, that patients should be advised to avoid contact with those with varicella infections. In case of contact, they should be advised to seek medical advice immediately. And we can give varicella zoster immunoglobulin, if available, is recommended within 96 hours of exposure. Okay. This is for treating people if they get varicella infections. Then hypovolemia, we discuss Addisonian crisis. That is the normal Addisonian crisis management. That is, the patient gets on long-term steroids, and there is something that the patient gets a fever while the patient is on steroids, or when, because they have been on long-term steroids, we know that that will suppress the adrenal gland. So when there is sudden withdrawal, or when there is some illness that causes it, leads to adrenal gland failure, then this patient can go into an Addisonian crisis. Then we usually manage with three things. Remember, Addisonian crisis, you give fluids, IV fluids, correct the blood sugar abnormalities, and give IV hydrocortisone. Okay, the main drug is this IV hydrocortisone that we give. Thromboembolism we discussed. Like I said, we don't give prophylactic. I said that before also. Remember, it's only when they develop. Then, yeah, this is the follow-up that we discussed earlier. Okay, the ophthalmology referral, fasting blood sugar, lipid profile, bone profile is done every 6 months. I think I didn't say that, so just remember that. Okay, you have to do eye screening because of the to screen for cataract. And fasting blood sugar also for steroids, lipid profile because of the nature of the disease, bone profile because of the steroids. Bone profile means we usually measure height. This is what they do usually, not they don't do routinely. Bone profiles. So yeah, I think that's all. I don't know if I missed any. Are there any places you want to do it again? Because I know that I went fast initially also. Are there any places where you want me to do some parts again? Is there anything else you want me to ask? Did I miss anything in this?
Naveen, what is the most significant cause for abdominal pain in nephrotic children?
Was that something they asked like that?
Yes, from one of the students they had asked something.
Significant.
Or the commonest, I can't remember exactly.
I don't know. I don't know what it's a significant. I can think of causes of abdominal pain in this thing. So you can get this renal vein thrombosis. There can be hypovolemia. Wait, there are some more causes of abdominal pain in this thing. But when you ask just one significant, I don't know what they're expecting. Maybe hypovolemia, because that's the thing you don't want to miss, no? But I don't know. Because it can be spontaneous bacterial peritonitis. All of that can be there.
Okay.
Yeah, I'm not exactly sure what they are expecting. Can be, yeah, it can be, even GORD can cause this thing with prednisolone steroids. Those are all cause of abdominal pain. Maybe it's hypovolemia is probably what they were expecting, but because of gut ischemia. But I'm not sure exactly what they mean.
Naveen,
Yeah.
can you again explain when you are starting the steroids for the first time to a patient, that how do we start and how we are going to taper it off?
So that part, steroid part, 1 minute. Yeah, so that only, like I said, we start initially with 60 milligram per their meter square body weight, their body surface area, and you start it for 28 days. Okay, so that is what we start. Before starting, remember you give all those advices for starting. You need to do that first, and then after that you start with this. So we give 60 milligrams per body surface area for the first 28 days. And once you give for those 28 days, we see if the patient goes into remission within those 14 days or not. If the patient goes into remission within those 14 days, then we consider the patient as an early responder. Okay. If not, then we consider you have to ask for nephrology opinion as to what to do with the steroids. What the nephrologist does, you don't need. Okay, so we'll skip this. Then for those first 28 days, you're giving prednisolone. No? Then after that, you have to give it again 60 milligrams per body surface area every other day for 2 weeks. And then you keep reducing the dose every other day for 2 weeks over 12 weeks. So we taper it over 12 weeks. So initially we give for 4 weeks and then we are tapering the dose over 12 weeks. So that tapering regimen is only given here. So you give 60 for 2 weeks, 40 for 2 weeks, 30 for 2 weeks, 20 for like that. You taper it over 12 weeks. And once you taper it over 12 weeks, you have to, so then we know, then you stop after that. So that is depending on whether the patient develops a relapse or whatever. And then, so we know the total duration we are giving it is for 16 weeks because we initially given it for 4 weeks and then we taper it over 12 weeks. That is the way we give prednisolone at that point. Okay, so these are just some additional things as to how to give prednisolone. We give it in a single day in the dose in the morning. We give it after meals, so you can say give it with meals also. It's okay. But when you're giving it, because they develop GI side effects, most of the patients are usually on omeprazole also. Okay, then you should not exceed more than 80 milligrams per day when you're calculating this dose. Okay, you can give it in two divided doses, especially if they are getting a lot of side effects, GI side effects. You can give it in two divided doses, and you give it in the morning and in the evening. And when you're doing that, we give 2/3 of the dose in the morning and 1/3 in the evening. The reason we give it in the morning is so that it matches your normal, circadian rhythm of cortisol in your body. So that is why we want to match that. That's why we give it in the morning as well. And also, yeah, that's why we're giving majority of the dose in the morning, even when you're giving them when you're dividing it in two doses.
Naveen,
Yeah.
this is when a patient initially comes. No, then
Yeah.
if a patient get relapse in between or relapse after complete remission,
Mm.
then is the regime is like this
It's the
or
same. That's why, because we asked Rangula sir that question and he said to use the same regimen, is what he said to us when we asked him.
okay,
But I
so
know that in some places it says something else, neither certain places.
if like patient relapse in between, again we start from the
Yeah, yeah,
prednisolone 60 milligram daily.
yeah, yeah, yeah.
Okay, thank you very much.
I think Hishana said it's hypovolemia, the significant cause must be that. Yeah. Mm, anything else? there's anything you want to ask me, you can text me and also ask later. So if there's nothing else, I can stop now. Saved. Okay.
Yeah, Majan. Thank you very much. Thank you.
Thank you.
Okay.
Thank you.
Bye.